Sure. Good morning, everyone. So I'm excited to introduce our speaker today, Dr. Caitlin Gostic. So Dr. Gostic is a James S. McDonald Foundation Fellow at the University of Chicago with Dr. Sarah Kobe as a postdoctoral fellow. She received her bachelor's degree in ecology and evolutionary biology from Princeton University. And her PhD is from UCLA in the ecology and evolutionary biology program, where she was advised by Dr. Jamie Lloyd Smith, who we saw earlier in our speaker series. Her work has centered around statistical modeling of infectious diseases, and particularly in thinking about the evolutionary and ecological dynamics of those diseases. I have to admit that her research was probably one of my favorite works that I read during my PhD, looking at influenza. And you all know that whenever we have a speaker here who has anything to do with influenza kind of competitive dynamics between strains, I always mention it. And her work really was foundational to a lot of my recent thinking about influenza strain competition. And I'm just going to go a little bit into it. So basically, there was this idea called original antigenic sin with influenza. And the idea was that the first influenza virus that you were infected with would subsequently kind of imprint on your immune system and influence the way your immune system reacts to subsequent influenza strains. As you all know, there's many different types of influenza strains. There's H1N1, H5N1, H7N9. There's all these different ones. Anyway, so her work was kind of looking at this original antigenic sin idea, but expanded it. And basically what they found was that there's some evolutionary dynamics in the relatedness between flu viruses, and those dynamics imprint on people's immune systems more broadly than was thought previously. And the study is incredible. I recommend anyone to go read it. And basically they were able to explain severe disease age distributions from H5N1 and H7N9 outbreaks using this model. And I think this model was really incredible because they were able to basically craft this idea, and the model that they created didn't even need to be fit to the data. It was able to just kind of explain the dynamics a priori, which is really, really cool to see. She has expanded that work now to show that similar dynamics are also helping to shape seasonal flu epidemics. So that kind of wraps up a lot of her work in influenza. She also has kind of a major focus in thinking about emerging infectious disease risk, where you may remember from Jamie's talk, she has done quite a bit of research into the effectiveness of traveler screening programs on preventing disease spread. With the focus in 2015, she worked on looking at, I think it was 6 different diseases, and she discovered how kind of the natural history of the disease impacted the effectiveness of screening programs. So for example, fever screening might be effective for diseases like influenza, whereas exposure questions would be more effective for diseases like Ebola that have long incubation periods. She also looked at coronaviruses and found somewhat mixed results at the time. And then she quickly adapted that model to think about COVID-19, and her early results found that under best case scenarios, we would miss about half of all COVID-19 cases just due to the undetectable nature of the disease. So the asymptomatic and pre-symptomatic phases, as well as just not having clear exposure knowledge. She's also now worked for COVID-19 on evaluating methods for estimating the reproduction number of the virus in real time. And I believe that's what she'll be discussing today. So I'll let her take it away.
Thanks for that really generous introduction, Spencer. Yeah, so I'm going to talk about estimation of the reproductive number today. But I guess while I'm pulling up my slides, I do think, or what I'm working on behind the scenes when I'm not thinking about COVID is related to the idea Spencer talked about at first, and thinking about sort of how an individual's history of exposure to an antigenically variable pathogen impacts future immune responses, including vaccine effectiveness. So there's some evidence for flu now that vaccinating the population with a given strain will provide protection in certain cohorts, but not in other sections of the population with different exposure histories. So I think that's a really important thing to understand. And I think there's a possibility that those kind of questions will soon become relevant for COVID. There isn't evidence yet that COVID is drifting antigenically, but we also don't have strong population immunity exerting selection pressure yet. So there's definitely some evidence that that may change in the future, given some of the analyses that we've seen for seasonal coronaviruses. But okay, so turning to the presentation, can everyone see my slides before I start talking? Great. So I'm going to talk to you today about sort of considerations for producing or interpreting estimates of the time-varying effective reproductive number, RT. And so, as I'm sure most people on the call are already familiar, RT is defined as the expected number of new infections that a single infectious individual would cause, accounting for changes over time in both population susceptibility, as well as changes over time in sort of individual behavior or interventions that might be reducing the underlying transmission rate. And so crucially, this is sort of an empirical quantity that we're trying to estimate using statistical models. I think it's a little bit conceptually different from the sort of theoretical version of R naught that a lot of people are first introduced to when they learn about SIR models. So I guess the general idea here is that if we were omniscient and we observed every transmission event, we could just go out into the world and count the number of new infections that each infected person is causing. And we could take the average on a given day, and that would be our RT estimate. In practice, since we can't do that, what we use are models that basically count the number of new observed cases each day, and that make assumptions about the amount of time that should be separating an index case from their daughter cases to try to sort of figure out the ratio of new infections to existing infections from the past generation. And so before I dive in, I also want to mention that pretty much everything I'm going to talk about today is summarized in this preprint, which should any day now be coming out in PLOS Computational Biology. And this was really sort of a team effort by everyone on the author list that grew initially out of us just sort of exchanging emails and Zoom conversations, trying to figure out how to make the methods that existed before the pandemic a little bit more robust to things like real-time estimation and reporting issues. So I'm not going to go into a ton of detail, but I just want to kind of briefly hit, I think, the three major points that we think are important from this paper. And then if people want to dive into anything that I talk about in more detail later, I'm happy to let the discussion flow afterwards. So the first thing that I think is important to know when you're using or generating RT estimates is that there are many different statistical methods available to produce these estimates. And it's important to understand the differences between them because different methods will produce estimates that are sort of shifted in time relative to each other. So some of the two most common methods, which were first described by papers published by Corey et al. And Betancourt and Ribeiro, these methods estimate something called the instantaneous reproductive number, which, as its name implies, is more of a population level average estimate of the reproductive number at a specific moment in time. And so if we look at this graphically, this estimator basically counts the number of new infections that are incident at a particular point in time, as shown by the downward blue arrow. And then it kind of takes the ratio of those new infections to the number and scaled current infectiousness of everybody that appeared in the data at previous time points, under the assumption that this previous generation of infections are the people who have progressed far enough that they're now shedding virus and causing new cases. And this little distribution represents what we call the generation interval, which is basically a probability distribution that describes the probability that exactly S days, a given number of days, would separate the moment of infection in an index case and their daughter case. So the instantaneous reproductive number is a little bit different from something called the case reproductive number, which is what you get if you use a different common method published by Willinga and Tunis. So the case reproductive number is much more individual focused. And so what it does is it looks at the cohort of individuals who first become infected today at time t. And it asks how many new infections those people will eventually go on to cause in the future as they progress through their course of infection. And so the key difference is that because the case reproductive number primarily draws on information in the time series after a time point t, it produces leading estimates of the instantaneous reproductive number.
Question?
Yep.
Sorry. Well, what do the curves represent, the green curve and the blue curve?
So the curves represent the generation interval. And so that's supposed to represent sort of the scaled infectiousness of individuals appearing at different point in the time series. And so I think so if you take anything away from this talk, remember that the case reproductive number is a leading estimator of instantaneous transmission. There's some reasons that you might want to use this, like because the case reproductive number is individual focused, it provides more ability for you to consider things like individual level covariates or heterogeneity between individuals. But if really what you're after for COVID-19 is an estimate of how strong transmission is today, then what you want to use is something that estimates the instantaneous reproductive number. Okay. So the second key point that I want to hit, which I'm sure all of you are thinking about a lot in other contexts already, is the need to adjust for delays to observation. So fundamentally, RT is a measure of transmission. And another way to think about is RT is a measure of new infection events, but we don't observe these infection events, right? What we observe are these lagged observations that occur days or weeks later of new symptom onsets or hospital admissions or even new deaths. And so it's important to adjust these lagged observations back in time so that they reflect the moment of an infection. And if you fail to do those adjustments, what you're going to get are lagged RT estimates, right? You're going to estimate RT that reflects transmission that was occurring days or weeks ago, but you might mistakenly label it as representing transmission that's occurring today. And so we can think a little bit harder about how best to adjust these lag observations using synthetic data. So both these panels show synthetic data that we generated using an SEIR model in which the underlying transmission rate first falls really abruptly, which simulates the adoption of public health interventions, and then later starts to rise. And so the important thing is that the yellow curves represent infections in the simulation observed at the moment they occur. So the yellow curves are like the real-time data that we wish we could observe, but that we can't. And then the green curves represent what we would actually observe in the real world if we're using a time series that reflects delays from the moment these individuals are infected to the moment that they obtain confirmed diagnosis using a PCR test or observed at the moment of death. And so there are two things to notice here. One is kind of obvious, right? The observations are shifted on the time axis relative to the infections. And obviously the size of that shift is longer for deaths than for infections. I think that's pretty straightforward. But the thing that kind of surprised us and that can be challenging to deal with, which is less obvious, is that delays to observation also blur the observed time series relative to the time series of infections, right? The peak in these observed time series is much more, is lower and also more smooth than the true peak in infections. And that blurring affects our ability to detect changes in the underlying reproductive number sort of at the true rate that they're occurring. So it makes changes in RT appear smoother and less abrupt. And if RT is really kind of bouncing up and down, this sort of smoothing can even sort of prevent us from detecting that those changes are occurring at all. And so we also thought about a bunch of different ways, statistical methods that you can potentially use to adjust. So to infer the underlying times of infection, which are shown in this pink, blue, and red curve from the observations. And so I don't want to go into a ton of detail here, but the takeaway basically is that the method that you choose makes a big difference. And in some cases, you can even choose methods that make things worse in terms of this blurring rather than making them better. And another thing to point out here is that sort of the stakes are higher in terms of which method you choose if you're working with a time series that has longer lags to observation. Right, so if you're working with cases which aren't lagged very much relative to the time of infection, kind of no matter which method you choose, you might be able to get away with a tolerable amount of error. It's easier to adjust for lags that are short and less variable. But if you're working with a time series of deaths, then you have to think really carefully about how you're adjusting for delays to observation, because as shown in this pink curve, which is actually, I think, one of the more intuitive ways to do this adjustment as a statistician, you're really not recovering the underlying time series of infection with any degree of accuracy. Okay, and the last thing I want to talk about is generation intervals. So we talked at the beginning about how the generation interval is this distribution that we use to sort of ground our RT estimates. It tells us what the expected amount of time is and should separate the moment that we observe an index case and their daughter cases. And this is true no matter which RT estimation you choose. The generation interval is always really important. And so this slide illustrates with the black line the true RT value from an SEIR type simulation. So this is from a simulated epidemic where we know what RT truly is. And then the colored lines are us estimating the generation interval using the method of Corey et al., which is the one we recommend, and then assuming that either we get the generation interval correct with the green line, or that we over or underestimate either the mean or the variance. And basically what you can see is that if we get either the mean or the variance wrong, our RT estimates are systematically biased. And these biases tend to be greatest when RT is substantially greater than 1, which is probably not the case anymore. So while this is a problem, I guess it's partially or a little bit reassuring, at least, that in the range near 1, where we probably are currently, we might be able to get away with inaccuracy in the generation interval. But especially at the beginning of the epidemic, the generation interval can be very important for obtaining RT estimates or R0 estimates. And that is a problem because the generation interval is extremely difficult to estimate accurately. So I'll talk in a minute about the difference between the generation interval, which is empirically defined as the time distribution of delays between the moment of infection in an index case and the moment of infection in a daughter case. In reality, what we usually observe is something called the serial interval, which is the time distribution of delays between symptom onset in an index and a daughter case. And so one of the challenges for RT and R0 estimation is that what the models desire is the generation interval, and not just the generation interval, but something called the intrinsic generation interval, which includes, it's a time distribution that includes all potentially infectious contacts. So sort of like R0, the intrinsic generation interval includes potentially infectious contacts that occur either with a susceptible or with a recovered person. It sort of doesn't care what the level of population susceptibility is at the time that you're measuring it. And similar to the way that sort of R0's independence of population susceptibility makes it difficult to estimate, the intrinsic generation interval can be really tough to estimate if you're not doing it right at the beginning of the pandemic, especially if the rate of population susceptibility is changing really fast. So another way to think about that is it's especially hard to measure if the epidemic is growing really fast. And to make things even more complicated, the quantity that we observe, the serial interval, is not only sensitive to changes in population susceptibility, but unlike the generation interval, it can also be negative, and it changes over time for reasons other than changes in population susceptibility, right? So the serial interval has also been shown to decrease over time, and this is due to things like public health interventions, where if public health interventions do a good job isolating people once they have a confirmed COVID diagnosis, then that's basically cutting off the right tail of the serial interval. It's making it much less likely that individuals are going to be causing new infections once they're past a certain point in their progression through infection.
Wouldn't that be true for the generation time as well, though?
So it definitely is. And I think that this is something that has taken me a really long time to think clearly about, but it's sort of like, there are a couple of reasons that the serial interval can change over time. And some of them we do need to adjust for to get accurate RT estimates, similar to the way R0 changes over time due to things like susceptible depletion, which are sort of incorporated into our dynamical models without us having to adjust for it a priori. And R0 also can change over time due to things like public health interventions, which we do have to adjust for in our dynamical models. So I think similarly, the serial interval changes due to susceptible depletion, which we don't have to adjust for a priori, but it can also change due to public health interventions, which we do have to adjust for. And it's not clear to me how important these biases are right now, because as I said before, we're probably in this range near 1, where the generation interval isn't really biasing our estimates in a huge way. But I think that sort of conceptually for the field, this generation interval confusion is something that should be pinned down a little better. And I will say that there have been some great papers coming out about this from Sang-Woo Park, I think he's a grad student at Princeton, and David Champerdon and Jonathan Dushoff. They've all been writing a lot about the generation interval issue. But admittedly, the papers are a little dense, so I'm not sure. I'm not sure how much people have really digested the issues that I'm bringing up. Okay, so that's all I had for today. But I'm happy to take questions or talk about anything that people find interesting.